There are 4 types of blood transfusion reactions that you will need to be familiar with, and these include the allergic, anaphylactic, febrile non-hemolytic, and hemolytic transfusion reactions. So in the allergic transfusion reaction, there is a type 1 hypersensitivity against the donor's plasma proteins. And these patients present with urticaria and wheezing. This allergic reaction is the only blood transfusion reaction in which you do not need to stop the transfusion. With the all other 3 types, you will have to stop the transfusion immediately. So patients who develop allergic reaction, you can treat them with antihistamines, like for instance diphenhydramine. The next type of reaction is the anaphylactic transfusion reaction, and this is seen in IgA deficient individuals. So what happens in IgA deficient individuals is that their body will start to form IgE antibodies against the IgA. And so once you transfuse them with blood products that contain IgA, so here is a mast cell with IgE receptors that are there. And as I mentioned, they have made IgE antibodies against the IgA. So what happens is that the IgA molecules will cross-link the IgE on the surface of the mast cells. And the cross-linking of the IgE receptors will cause the degranulation of the mast cells, and thus histamine will be released, which causes the anaphylactic reaction. And so these patients will present with dyspnea and bronchospasm, and you will need to stop the transfusion immediately and treat them with the epinephrine. The next type of reaction is the febrile non-hemolytic reaction, which is a type 2 hypersensitivity reaction against the donor's HLA antigens, as well as the contaminating leukocytes that are present among the red blood cells. And these patients will present with fever, chills, and flushing. And finally, we have the hemolytic transfusion reaction, which divides into acute and chronic hemolytic transfusion reaction. So acute hemolytic transfusion reaction is happening in response to the ABO incompatibility. So if you transfuse someone where there is an ABO incompatibility, there would be an acute hemolytic transfusion reaction, which causes the intravascular hemolysis that causes presentation with flank pain and hemoglobinuria. On the other hand, if you transfuse someone with an antigen, like for instance the Rh antigen, and then later on you transfuse them again with the same blood products that contains the Rh antigen, the body can now mount an immune response that causes chronic hemolysis. And this is an extravascular form of hemolysis that causes jaundice. And the chronic form is less severe than the acute transfusion reaction. Now, speaking of the Rh antigen, I want to remind you that if a mother is Rh negative and her child is Rh positive, if the mother's immune system comes in contact with the child's blood, what happens is that her body, the mother's body, will start to form IgG antibodies against the Rh antigen. And thus in the second pregnancy, so this first child will be okay, but in the second pregnancy, since there are IgG antibodies that are now present, the IgG will cross the placenta and causes the hemolytic disease of the newborn. And the only treatment that now you can provide to this child here is that you can provide intrauterine transfusion with the blood. But if you wanted to prevent this problem, what you had to do was that during the first pregnancy, at 28 weeks of gestation and postpartum, you had to provide the mother with the RhoGAM antibodies. And what this RhoGAM does is that it will hide the fetus red blood cells, Rh antigens, against the mother's immune system. So mother will not recognize it and thus will not form any IgG antibodies. But if the mother has already been exposed and the antibodies are made, there is no point giving RhoGAM here anymore because the IgG is already present and there is nothing that can be done except to provide transfusion during pregnancy to the fetus. And that concludes our discussion.